We have a female with 50 years old with a gastric pain since 3 months and gastroscopy and colonoscopy normal. CT scan showed a 35 millimeters pancreatic cystic lesion in the body, as we can show it in the next slides. Napoleon group showed this year a good correlation between the pathology and the endomicroscopy founds in microvascularization of serous adenomas. They also showed an 100% specificity and a good accuracy, 83%.
First, we can a bit discuss and characterize this lesion. So you see it's a thin-walled lesion. You can nicely see the wall. It's about, we can measure it, it's about 4 centimeters. So a bit bigger than described previously. You see it's 4 centimeters and the other diameter is 3.8. So it's a bit larger. And then it's completely, the fluid inside is completely clear. Now, there are some tiny blood vessels. You see I have the color Doppler on, and if I increase a bit the lesion, you can see that there are some tiny vessels on the wall. So that's what we can say with the usual endoscopic ultrasound and with the Doppler. Then we are also, it would be interesting to see the relationship with the pancreatic duct, and you see we have a very nice system with a very good resolution, so we can enlarge the image, so I can do it a bit even more, so you can appreciate the resolution for the pancreas. And then if you try to follow my pointer, then you'll see that the okay, Fabrice can help me a bit. So now you see the pancreatic duct. So it's really nice, and if we follow the pancreatic duct, you see that it actually communicates with the lesion probably here.
Okay.
So yeah, Fabrice will show you the needle and the confocal. We're using the Cellvizio, so the needle-based confocal laser endomicroscopy, and it's a tiny fiber which goes through a needle, and we're using a 19 gauge needle. And
Okay.
Fabrice will show you the
Do you see the needle? Do you hear me?
Yes, we can see the needle nicely.
Okay.
okay.
So we will use a preloaded probe. The probe is in the needle. Alors. Okay, you see the needle with the probe here. The probe has to get out of the needle. Voilà. You see? The needle is out, the probe is out.
Yeah, we see that.
Okay. So we have a system to remove a bit the probe, and we will punction with the needle without the probe to avoid to break the probe, of course. And after punction, the probe will be out of the needle.
Okay, so we will try, and whenever you do the fine needle procedures, you have to be careful and avoid the big vessels. So you see the splenic artery and the splenic vein, so you have to move away from the big vessels. So now we have to locate a place where there are no vessels in between the gastric lumen and the cystic mass. So I think here is okay. What you see on the ultrasound image is you always see a marker, an H. Okay, it's a bit long.
We have to inject fluorescein.
Yeah.
Could we inject flu? It's done. Okay.
Adrien?
So it's done. We have injected fluorescein because
Adrien?
Yes. it's
Is the probe changed the fixity of the needle?
yeah, a bit, but I think it's a 19 gauge needle. So of course, it's being a 19 gauge needle. Sometimes the puncture is not it's not easy, especially from the stomach and also from the duodenum. Sometimes it's very difficult if the scope is bent a lot, but it's not much. I mean, the probe is quite flexible, so it's not really a problem for the needle, I think. But we will try to puncture it, and then let me see if I can get it here, and then we'll start the imaging. So you see that the stomach wall is going a bit away, but now we're in. So
Very well.
and now we have the 19 gauge in, and now we can also advance the probe and start the.
Can you just remind us how far you feel comfortable advancing the probe?
Yeah, it's not much. It's usually 1-2 millimeters. But if you look on the ultrasound image, you can actually see the probe moving from the tip of the needle. So it's exactly near the pointer here. So if you look, you can see that I can move the probe, and you can actually see the probe inside. So we're not advancing too much, because if you're getting it out, you can fracture it inside, let's say. And what we can do then is to target the wall, so you can move the elevator. And
Sorry.
now it's okay.
I will fix it.
Yeah, that's perfect. Okay, now we already have some images. So
So you've locked the probe there.
sorry. Yeah, we've
You've locked the
locked
Yes.
the NCLE probe on the needle, and you can use a fanning technique. So you try to sample the cyst wall in different parts.
There's a lot of dark point.
Yeah. So I'm trying to keep it still. That's one of the problems with endomicroscopy, is that the resolution of images is very high, and then you get a lot of course, of artifacts if it moves. So I'll try to keep it, let's say, still here. So now we see a lot of let's say it's probably erythrocytes and a lot of it's a lot of erythrocytes probably flowing, and cells and debris flowing
Macrophage maybe.
in fluorescein, yeah, and macrophages also. So it's a lot of cellular elements, let's say, flowing in freely in the fluid. But I'll try to advance a bit.
Could you just remind the audience when you injected with the fluorescein?
Yeah, you can inject it immediately before the puncture. Usually it lasts for 20 minutes, 30 minutes. So you can do the imaging for 20-30 minutes. Okay. So maybe now we have some better.
As you're doing this, for those of us who are not routinely doing this, can you remind everyone what you're looking for? What specific criteria you're looking for?
Yeah. So the discussion now is what kind of cyst, of course, and you know that there are already published criteria. So for serocystadenoma, there is a superficial vascular network, but I cannot really see it here. I'll try to advance a bit on the on the wall.
It seems to be a pseudocyst.
Yeah, but the other thing is that it might be if we look here, maybe it's a bit. Now it's a bit
We have
on
to
the
touch
septation,
with
yeah.
the needle
in different
most
parts.
of the wall of the cyst to look for vascular
No,
network.
it's not.
No.
It's not. It doesn't look like a serocystadenoma. Now you see some vessels there,
Yes, but
we will go retrospectively.
Not
yeah.
network.
No, it's not a superficial vascular network, which is characteristic for serocystadenoma. So we want to look for serocystadenoma for the superficial vascular network.
IPMN.
Then we want to look for papillary projections, which are more specific for IPMN. And then in this case, because it's a young, relatively young lady, so we will look also for mucinous cystadenoma. So maybe there are some structures here. The problem is that you have to record the movies and sometimes look retrospectively, maybe together with the pathologist after the images. So it's not always easy to see things when doing the exact imaging because they are moving pretty fast.
The sign of mucinucyst is difficult to see because it's only
Yeah.
a thick band.
Yeah. Now you see maybe some bands which are probably more characteristic of fibrosis probably on the wall.
Can you remind us how long you're comfortable staying in the cyst with this procedure?
Yeah, it should be 2-3 minutes, not more, because there is a risk of acute pancreatitis. So we don't image, let's say, more. And then what you can do is either you extract everything, get the fiber out, and redo the puncture, or we can try to take the, let's say, the fiber.
Can you
I'll
try
try
to go down?
Yeah, I'll try a bit.
It's difficult, I know, but
Yeah, it's a bit difficult, but and I cannot get it
Can you
more
precise
with the elevator.
which is the size necessary for perform PCLE? Can you precise the size of the lesion?
the
Because
size.
sometimes a small lesion under 2 centimeters is difficult to perform this procedure, I think.
That's probably a limitation, but we included for the moment in in the 2 studies cyst above 2 centimeters.
Yeah.
But probably for cyst under 2 centimeters, it will be difficult. Yes. For the moment, it is difficult to have CLE and tumoral markers in the cyst for. If the size is under 2 centimeters. That's the reason we did not include this cyst, but that's maybe that's a limitation. It's a limitation of the function.
Yeah,
And do
from
you
time to
perform
time the
systematic
images
blood
are better. Yeah.
Antibiotic prophylaxis by antibiotics
Yes,
during the procedure or
all
before?
function. Yes, like all cyst function, we perform antibiotics before. Yes.
Yeah, it was. Yeah. Yeah, I saw it
artifact,
also.
I think.
Yeah. And that was a vessel. That's a vessel.
vessel.
There.
So-
Yeah.
You see the vessel? We can't. It's a white band on the image.
Come back.
A bit back.
No, this one, yes. Maybe, I don't know.
No.
No, this is artifact.
Yes.
That's an artifact. Yeah.
We are looking for signs of mucinusis because mucinusis can be infected, and we can.
No.
Yes.
This could be a cystic neuroendocrine.
Yeah, but
Just I think it's just an image.
yeah. So we'll take some images and also.
Well, we are sure that we can exclude definitively the serous cystadenoma.
Yeah, it's
because
not
there
serous.
is no the network, and now the next step is to aspirate the liquid and
Well, I think it's
to do the standard.
I think it's a pseudocyst.
okay, but I think it's very important to see the color of the fluid also. Ah, yes,
Okay.
you see.
Yeah,
I mean,
pseudocyst.
maybe it's a pseudocyst, yes.